So now we'll be hearing from Dr. Ray Bogany, who is a primary care physician, internal medicine with Kaiser Permanente in San Diego. Ray joined Kaiser in 2003 and has helped lead outpatient quality for the Kaiser members in San Diego.
So hello, nice to meet many of you and nice to see others again. I was in this exact same room in January with the Right Care Initiative, yes. So, Right Care Initiative?
Yes, you were.
Okay, so
We were all here.
yes, excellent. So some of the slides may look familiar, but I'm gonna go blow by those.
Don't worry about it. Don't blow by them. They're really good.
Oh, thanks, Hattie. And I didn't even pay her for that. So who's our gentleman? Kirby had to pay somebody. I didn't even pay Hattie for that. As I was introduced, I am from Kaiser Permanente, so that is the only thing I really have to disclose. And so, Script Your Future, this is for Elaine and Rebecca. You see how I put in the PowerPoint the little X there to make it an RX? I tried with my skills. So these are my objectives, and I call them objectives for spread and sustainability rather than learning objectives. But that's what they are. Earlier today we heard take-home messages, so they're the same thing. I'll just let you read through those. I know all of you can read, it's just a matter of vision. Earlier, right, Peter mentioned vision, and so, or aging, right? And so hopefully it's large enough so everyone can see those. And so, any questions about those? So that's what we're gonna tackle. So, again, I have nothing to disclose, no commercial interest. My content is fair, it's balanced, unbiased, other than it represents the work that we're doing at Kaiser. And so at Kaiser, our little today for the San Diego County overview, and then one condition at a time. So these are the kind of the agenda that I want to go through to meet those learning objectives. So with that, every organization has a mission and promise, values, etc. Yes, these are what we have at Kaiser, and this is Kaiser nationwide. And so with that, providing high quality, and then it's affordable health care. So I do take a moment to read over this because the key words are high quality, affordability, and then improving the health of our members in the communities we serve. So not just Kaiser patients, but the entire community, just like what we're doing here. And so I bring this to you again to show you how large California is. I know we have some from out of state, which is great. And so San Diego County sits down south, right at the border. And that, of course, is going to be significant for our patient population. So just like Santa Barbara, where did Joan sit? Just like Santa Barbara has a population, being close to the border has a very different population. And then that's San Diego County pulled out. And so if you look at that, let's see if this one will get my little pointer. So in here, the central part of San Diego is where I work. I live up here in Poway. We travel the coast, which is going to be different, and then you go inland, and that's where we tend to have the heat. And unfortunately, like you're experiencing here in Northern Cal, that tends to be where our fires attack, right? The Cleveland National Forest. And then what state's over here? Arizona. So that's also going to change our population. Patients will drive in from Yuma and come into Kaiser. This at the top is Camp Pendleton, and I essentially consider Camp Pendleton like it's going all the way across. However, that's our border, and up here is Orange County. So I like to mention within Kaiser, Orange County is its own area as well for members. And so with Orange County, there's a little competition, and you probably all in here age-wise might remember, what is it, Beverly Hills 90210, and the Orange County Housewives. I hope, well, it's your choice if you want to watch that show. That occurs up here. And so a little bit different than our population. And so to start off, one condition. Earlier today I did hear Kirby, where's Kirby, his team with the pharmacist? Oh, right here in front of me. Kirby was talking about the many conditions, right? So there are all of those chronic conditions that I kind of look at as he just wants us all to get control for our patients with those numerous, right, conditions. So rather than talking about all of them, I tried to kind of narrow it down just to one. So I like to tell a story, and so continuing from January with hypertension and how Southern California and then San Diego specifically increased our blood pressure control, I figured I would just stick with that, huh, Addie? And stick with just hypertension. And it is like, you know, speak about what you know, right, and what your comfort level is. So with the improvement process, you may have seen this slide as well, but it's about the numbers. Everybody today is asking about statistics. I actually majored in undergrad in economics. I love numbers. I love stats. So finally, it took me lots of years since I was an economics major at the University of Maryland to realize, when am I going to get to use the numbers? So every day there's blood pressure numbers and cholesterol numbers, right? How many asthma, what are they, controller medications and rescue inhalers someone is prescribing or picking up. But it's really the numbers, right? All that we're talking about has to do with numbers. And that I call kind of the what. So we've got these numbers. Then we go to the why. And the why, I think my mic just cut off, but that we go to the why. So we take those numbers and we want to talk to the staff about the why. So they know how to come in and check a blood pressure. Why? They're just taught, just check the blood pressure and it has to go into the computer, or if you're not on electronic medical records, it needs to be written down. That's all they know. Just, they need to check a blood pressure. Why? Why? And how to properly do it. And then provider algorithm. For us physicians, we're also a unique profession, and we don't exactly like to be told what to do. So if we're going to be asked, and I say asked what to do, then we need to know, again, why, and what's in it for me? What am I going to get out of it? And so, definition of blood pressure control. Who can state all of this without looking? Anybody? Anybody? Anybody know JNC8 without looking? I don't even know JNC8, so it was a review for me. So if you just wanted to take a look at this, this apparently is what our new definition is. Because if we're going to measure blood pressure or measure diabetes or measure cholesterol, well, what does it mean? So we've got patients 18 to 59. I thought it used to go to 75 or 85, but 18 to 59 inclusive, and they've had their blood pressure less than the 140/90. They're in control. Can we say yay? Less than 140/90. So what does it mean if they're 141? Or if they're 91 or 90, are they in control? No. So it needs to be less than 139 and less than 90. So when I talk to patients, I actually put on my after visit summary at Kaiser. We can print those off. I tell them the blood pressure goal is 110 to 139, and then I'll say 50 to 89, so that we don't even bother, because most people, the less than and greater than. And so then we've got patients with diabetes, the chronic kidney disease risk group that are 60 and over, and the last blood pressure in the last 12 months was less than 140. Okay, repeat that. Or, now what's the next one? The patient who doesn't have any of those, and they're over 60, and now what's the blood pressure supposed to be? Right. So then now my after visit summary should say 110 to 149 over 50 to 89. How many of you think I changed what my after visit summary says? Correct. Because, well, I don't know how you are, but back when you were younger and your mom said you could have a cookie, you might say, can I have two? If you're like my 10-year-old, he might want to add some chocolate sauce or some sprinkles he finds. So his one little cookie went to like the sugar level. Joan was talking about, wow, hi. He doesn't have diabetes. Thank goodness he plays soccer because, oh boy, he drinks lots of fluids. So the CKD risk group, do we know what that is? Those are what we call the equivalents. So they don't meet the criteria. Now for us, POINT, if you hear me reference POINT, it's actually a pharmaceutical-driven database that we have at Kaiser. So one of the things that I do want to say today is, yes, I do work within Kaiser Permanente, within the medical group. So we have the electronic medical records. We're working on, well, we have the medical home. We're meeting those Medicare standards and those standards. So one thing that I want to express to you is, yes, I work at Kaiser. We're not perfect. We still have room for improvement. So we're in the same, as we say in San Diego with the Navy, we're in the same boat together, right? There's always room for improvement. And that's what today is about. So we need to identify these patients, right? And we want to treat them, and then we want them to adhere to our medicines that we prescribe if that's what they need. So we're all in the same boat. So how do you identify patients with high blood pressure? You first have to identify them. And we found within our data, for those that love numbers, that 18% of newly identified patients were in a specialty clinic. So one of the things we talk about with primary care, right, we talk, what about the specialty departments? We mentioned the pharmacist, but what is the role of the general surgeon, the vascular surgeon, orthopedic surgeon, neurosurgeon, internal medicine specialties? And 14% of them, look how high those blood pressures were. So this data is a little bit old, but that's what we found, which led us to inclusion of all specialties when it comes to identifying patients with high blood pressure. So these stats show that about 60% of our members were actually seen in specialty care, and that remains true. Not many patients want to come see me anymore. They'll send what, the email, they'll call. Will you refer me to the dermatologist? Will you refer me to the endocrinologist? Will you refer me to the orthopedic surgeon? So only 40% might come through my door. So that's why specialty care is really important. I see Hattie's nodding her head. She loves that when I say that. So the improvement process, and it's a process. So again, we go back to who's involved. And again, it's everyone. So we mentioned the continuums this morning, right? Leah mentioned the continuum of medication adherence. So we have a continuum here, and highlighted in red is the discussion of hypertension or whatever that condition may be at every visit. And so for the purposes of today, it's hypertension. The patient comes in, they're going to get the blood pressure checked. Look at the blood pressure, right? Compare it to their previous blood pressures. And then I put in red there for Elaine and Rebecca. You got to discuss the meds. And our pharmacist. Oh, I admire our pharmacist so much. I would, if what is it, the American Idol show, if you heard me say that, for me it would be the pharmacist. Oh, I admire your work so much. So it's discussing the medications. And specialty, they need to know what they can do, because remember, now, are there any specialists in the room? Because I don't want to, well, I guess I kind of do, kind of offend you. I have 3 brothers, and it's just the way I am. I kind of instigate, and Elaine knows that, and she's still inviting me back. So anybody a specialist in here? Surgeons, internal medicine, we have cardiologists, endocrinologists today.
I could be a rheumatologist.
Oh, she could be a rheumatologist. Okay, good. Well, the good thing for you is I'm from Philadelphia, and we talked about you to your face. We don't talk about you behind your back, so that's good. I just want to make sure that I'm not going to talk about anybody behind their backs. Just let everyone know that up front. So when it comes to the back office staff, actually I have another set of handouts that you're going to be getting today after, actually it might be in your packets. So did you get your packets? So I was trying to put them in order. I'm not sure if they're in order, or it might be in the second set with sodium. Let's see which. Yes, it's actually in the second set of handouts. So you're actually going to get that today. Just an example from Kaiser with what we give to patients. So this handout was edited in 2000. It was created in 2012 and then edited in 2014. And so it still goes to show just giving patients with high blood pressure a handout. So if they had the diagnosis of high blood pressure, or if they came in and the blood pressure was high, just give out this handout. Now something I put in bold there is the salt maximum. So sodium is another controversial, right, with the numbers. So I guess we should start. How many milligrams of sodium does the average American consume in a day? More?
36.
More? More? Close. Under 10, it's somewhere about 7,000 milligrams of sodium a day. So by telling a patient 1,500, are they going to get there? But they'll at least start reading labels and cut it in half. So that's where patients come back and say, Doc, did you know bread has salt? Yes. What, my barbecue sauce has salt? Yes. Any of the processed foods, any of them, right? And of course we know seasoning. So that was just one easy step. Then we did academic detailing with the staff. So with our electronic medical records, there would be an alert, check the blood pressure if one is needed. If you're in a specialty department, they didn't even have to check it. So there you go, making it easy for those specialists. However, medication reconciliation at every visit to verify the meds, because how can a surgeon go in to operate on someone if they don't know what meds, or more importantly, the anesthesiologist, right? So even the specialists need to know what the patient's taking. And then this data is presented unblinded, how the back office staff is doing their blood pressure checks. And I'll show you that in a moment. Of course, accuracy, and this has been changed. So for Hattie and Liz and the others that have heard me before, it's now less than 60 for standing. How many of you check a standing blood pressure? So, oh, Liz does, excellent. So, yes?
So this is confusing because the American Medical Group Association during PENSO's campaign for Measure of Pressure Down is you're supposed to be sitting quietly for 5 minutes, no talking. So can you talk about why the standing for the over 65?
Excellent. So we don't have any nephrologists in here. However, medications that we use to treat patients for high blood pressure usually involve what? Diuretic. What's that going to have the patient do? Lose? You didn't know this was going to be a physiology quiz, did you? And so they'll lose water. So then they might sit, relax, and then you stand them up, and what happens? You got it. So we used to say over 70, and in preparing for this, so Elaine, that was the delay in getting to Elaine step out. The slides tour is because I did the research to make sure what I'm presenting is what still holds true for Kaiser, and this changed. Whoop, 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 sorry. I went too fast. It used to be 70, and that is because of orthostasis. And any patient that's getting dialysis, whether peritoneal or hemodialysis, is large volume diuresis, right? So nephrology takes all of their patients' blood pressure standing if they're there for end-stage renal disease. All right. Then this is actually an email that our regional hypertension lead, Dr. Joel Handler, sends out. So he's the regional lead, and he sits on the national boards that help develop the guidelines for the United States. So with Peter coming out of NIH. And so he sends this out. Yes, I kind of truncated it to fit. But this is actually if our staff is checking a second blood pressure. And so unfortunately, San Diego's down here. 90% of them are checking the second blood pressure. So what this means is if the first blood pressure is over the 140 or 90, or now over the 150 over 90, the staff is to check a second blood pressure and put it in the computer. If they don't, which in San Diego, 10% of the time it's not happening, and our regional goal is 93%. So again, there's stats and ways to measure. Did I skip one? No, I didn't. So then additional strategies. This is focusing with the African Americans. So when it comes to primary care physicians, the providers had what we would call academic detailing, and for the primary care physicians and providers, review, it's what I call the pharmaceutical drug rep rounds, where the healthcare team leader, the module leader, the building leader would mention just key hypertension messages, watching the sodium, are you taking your medicines, what time of day do you take them, etc., to look into that medication adherence. And of course, giving little gifts, things like that. But then you notice the bottom, unblinded data. So the hypertension stats. We did physician CME. Yes, Denny's is unhealthy. And how to ask about medications. And so the reason I bring this up is because we're going to get to the spironolactone in a moment when it comes to disparities. Actually right here. So when it comes to the algorithm, so when I was here in January, really focusing on an algorithm, and that might be part of your handout packet with the, oh, there we go, go ahead, I understand yesterday.
Well.
Did I hear that?
We've developed one. We've developed one, it's just JNC8.
So-
So if groups want to get them, we have, Dr. Remlo did do that work since you got us going.
Yay, thank you, I'm so glad. And so just going through some type of algorithm, and this is also true for the pharmacists in the community, right? So say a patient comes to Kaiser, and now with the Affordable Care Act, patients may not have to, so to speak, have coverage to get meds at Kaiser anymore. So they might go out into the community. So they may see one of our community pharmacists. So I would want the community pharmacist to be on board with, well, Ms. Bogany, we're taking this Prenzide and you're only taking a half a pill. Have you spoken to your doctor about an increase because your blood pressures are high? So to be on the same page. Chlorthalidone, old school medicine. That medicine actually works very well in African Americans, and then the spironolactone. This is information that Elaine wanted me to share. So back in 2010, this was data that got us motivated at Kaiser, again within our point internal data system, to look at what medications. So earlier we were saying, I heard questions, what medications are, with the disparities and med adherence. So you can see, this is for African Americans, greater than 4 prescriptions. Do you see that? Greater than 4 prescriptions for blood pressure? And look at their control rate. So what does that mean? If someone has more than 4 prescriptions prescribed, and that's their control rate, what's that mean? Exactly. So then we went down and we said, well, let's see in this time period what meds. So I kind of put here in red, you can see it better on the other screen, with what medications they were taking. So this is why with that Prenzide at the top, the combo. And what happens with the ACE inhibitor and ARBs. The thiazides, and then I highlighted where spironolactone actually works very well in African Americans because of the really the salt sensitivity. So some research, when we talk about research, has shown that African Americans are more salt sensitive. And so in San Diego, this disparity, so when we look at outcomes we were talking about earlier when I was here in January with the Right Care Initiative, I presented data that went from 2012 when we actually started looking at the hypertension disparity. And so then that data there from the medications and putting it all together. So just as our panel said earlier, it's not that the patient can walk into my office today and I can do this alone. Because who do we need on the team? We've already talked about it, right? It's a team. And so from August of 2014, we were here, and you see what happens? Our goal is 3.2% disparity. And there's some that say it should be what? 0. So we managed to get it down to 3.2, and then it traveled up. Now, why do you think that is? See how it traveled up a little bit, traveled up, and then we're now trying to come back down here. 4.8% in August.
On the other hand, for both whites and African Americans, you're well above the national 90th percentile.
Oh, excuse me, Hattie, I didn't hear you. Could you repeat that? So thank you for having, I tell you, I don't know what she wants, but you might want to come to San Diego or something to visit. And so the control rates, we do work hard to be up in the national 90th percentile. Top 10. And so in San Diego, so we say, okay, so we're not at our regional Kaiser goal of less than 3.2%, but we're above national. Why? What does that matter? Why do we still not like that we're at 4.8%? Why do we not like that? Outcomes, what happens when blood pressure is not controlled?
Heart attack, strokes?
There you go. There you go. So complete care comes into the picture. I was the physician director of this department from January of 2010 through August of last year. And complete care is person-focused, right? Total patient care. Those are the buzzwords. Population health. So with that, the top box I put there in green because you'll see reducing African American hypertension disparity. And so it's behind the scenes work. These are where our data analysis come from. This is where the information on the Prescriptions, how many prescriptions? So at an advantage with the electronic health system where we can pull all of that out, it was probably about 5, 6, 7 years ago we started to collect race and ethnicity information, which helped us to determine all of this. And so earlier today it was heartbreaking to hear Leah, where did Leah go? Right here, with 17 years from research to putting into practice, she said, you know, half of, what do you call it, a career, thinking 17 years, that's a long time. So all of us here want to jumpstart things, right, and get them moving faster. That's why there's so many wheels working at one time. And so an article, this one from the Joint Commission on Patient Safety, outreach. So this is what's big. So I talked a little bit, there was the one slide on focused outreach. So African Americans, you get focused outreach to the Latino population. Wherever you may live, focused outreach in pockets outside of LA with Asian population. Focused outreach, and so going back to those meds, this is where again, we go with the Prinzide, max it out. We would contact patients for the thiazide naive. And then we would add the spironolactone. Culturally responsive care, so this is key. So you may have seen one type of version of this particular slide where we used to say equal care, but now what's the new buzzword? Can't hear you. Oh yeah, the answers are always on the slide. Oh, and I didn't tell you my mother's a retired teacher. Some may have heard that, so. So equitable care, it's about equality. And so with equitable care and health outcomes, this is actually a department that sits in our program offices in Burbank. And so 4 habits, 8 it, and then enhancements to that. And so when we were talking about how to communicate with the diverse population, or the underserved, the underrepresented, to get equitable care, this is where you would walk in to see me, no matter my age, unless I was, you know, under 21, and you would say, hi, Mrs. Bogany, I am pharmacist such and such, I am nurse such and such. It has to be the surname, Mr. or Mrs. A must. You must shake hands. You must look us in the eyes. So earlier at the table, I was talking about that E-Trade commercial, right? I'm watching you, watching him. You remember those commercials? I was actually sharing, I can stay up on these things because I have kids. They keep me up on being cool, even though they don't think I am. Very, very important. Shaking hands, looking someone in the eye. I will have patients switch to me, and they will say, this doctor, they didn't even look at me. This doctor, they didn't even touch me. Patients don't think the stethoscope is touch. It has to be, hi, I'm Dr. Bogany. Nice to meet you today. I understand you're a patient of Dr. Such and Such. Usually it's thank you for your patience. And what's the joke after that? I'm a patient. How can I be a patient without patience? And so that is so important. So important. And then to thank them. Even though they've taken more than my allotted time, I thank them. Thank you for your time today. Very important. And then this one also, you'll see this is more details about that. So important when it comes to the rapport and having that relationship to help close those disparity gaps. I will have patients come see me to this day and say, the doctor never told me why I need to take Prinzide. They never told me I need to take the statin. They didn't tell me what metformin was for. So pharmacist, one recommendation that we do, that I actually do, is on the prescription, how many of you say or see Prinzide, whatever the dose, 1 every morning by mouth for blood pressure control. And I don't say for blood pressure, I say for blood pressure control, for diabetes control. The cholesterol medicines I have, and they say to lower cholesterol and keep arteries open. And then the patients could come back and say, what are arteries? Most don't because we've already taught them. So important. So important to actually, as I said, be a teacher when you are with the patients, especially closing those disparity gaps and to obtain the medication adherence.
Will they print that on the label?
Yes. Pharmacist, actually, my understanding is by law must print it. So one of the things I do to get control of my other gaps is, one of my favorite is, oh boy, let's see, we call that for the men, the erectile dysfunction medication, that they need to get their fasting labs before they can get that medication. And boy, will they get their